Good afternoon. Welcome and thank you for joining today's webinar. My name is Kelly Parker. I'm the Director of Emergency Preparedness at the Virginia Hospital and Healthcare Association, and I'm joined by my colleagues from the Association and from the Virginia Department of Health's Office of Epidemiology and Office of Emergency Preparedness. Today's webinar is intended to provide the hospital community an update on the outbreak of the 2019 novel coronavirus in China, the impact in the United States and Virginia, and to provide guidance on caring for persons under investigation for the novel coronavirus. Today's webinar is being recorded and will be distributed to registered attendees after the call. Any questions received prior to today's webinar will be answered throughout the presentation. We will be answering hospital-specific questions today. All lines have been placed on mute, so if you have a hospital-specific question, please place the question in the chat section of the WebEx. As time permits, we will answer questions on this call and provide answers to all questions with the distribution of the recorded webinar. We would like to remind everybody to please keep your phones muted. I'd like to introduce today's speaker, Dr. Lillian Peek. Dr. Peek is a state epidemiologist and the director of the Virginia Department of Health's Office of Epidemiology. She's been a public health leader for more than 19 years, including time spent as the director of the Thomas Jefferson Health District, the director of VDH's Office of Family Health Services, and the deputy commissioner for population health. We are thrilled to have Dr. Peek here with us today and to provide an update on the novel coronavirus outbreak and hospital preparedness. Dr. Peek.
Thank you. Good afternoon, and thank you for joining us today. On December 31st, the World Health Organization was notified about a cluster of pneumonia cases in China. A week later, scientists in China had isolated a novel coronavirus called 2019 nCoV. By January 19th, the CDC had finalized development of a real-time reverse transcription PCR test, and utilizing that, the first case was confirmed in the United States on January 21st. The initial 44 cases identified had exposure to the same seafood market which sold a number of animal products. It's located in the city of Wuhan in the Hubei province of China. Located about 700 miles south of Beijing, Wuhan has a population of 11 million and is a major domestic and international transport hub. Since that time, the number of confirmed cases has been steadily climbing, as has the number of cases identified in other countries, primarily among travelers from the Hubei province. Yesterday, the count topped 6,000. 99% of confirmed cases are in China. 68 cases are in 15 countries outside of China. This map shows the distribution of cases. 5 cases have been identified in 4 U.S. states among travelers who recently had returned from Wuhan. They are in Washington State, Illinois, Arizona, and 2 cases are in California. More cases are likely to be identified in the United States in the coming days and weeks. At this time, it's important to note that there is no person-to-person transmission that's been detected in the United States. Thus, CDC considers the immediate risk to the general American public to be low. People exposed to ill persons are at greater risk of infection, so therefore, healthcare workers and family members caring for people with 2019 nCoV would be at higher risk. The situation is rapidly evolving, and future risk will depend on how well the virus spreads and how sick it makes people. Beginning January 24th, China has enacted a number of travel bans. Today, the World Health Organization Emergency Committee on the Novel Coronavirus under the International Health Regulations will meet again to evaluate the situation. Coronaviruses are large, enveloped viruses with a single-stranded RNA genome. They can cause disease in both mammals and birds. Genome changes caused by recombination, gene interchange, and gene insertions or deletions are common among coronaviruses. Rarely, animal coronaviruses evolve to be able to infect humans and then spread from person to person. We know that bats are an important reservoir of coronaviruses. The initial source of this novel coronavirus is still being investigated, but it is likely from an animal reservoir. The coronaviruses that cause SARS and the Middle East respiratory syndrome Both beta coronaviruses originated from bats. Peridomestic mammals may serve as intermediate hosts, facilitating recombination and mutation events with expansion of genetic diversity. In 2017, the World Health Organization placed SARS coronavirus and MERS coronavirus on their priority pathogen list, hoping to galvanize research and the development of countermeasures against coronaviruses. Human coronaviruses were first identified in the mid-1960s. 7 types are now known to infect people. Most people will get infected with at least one of the 4 common human coronaviruses in their lifetime. These viruses usually cause common cold symptoms, and they're typically in the upper respiratory tract. Symptoms start 2 to 14 days after exposure, and they're spread from an infected person to others through coughing and sneezing or close personal contact. 2 highly pathogenic coronaviruses have previously caused serious epidemics, SARS in 2002 and the Middle East Respiratory Syndrome, or MERS, in 2012. Both affected the lower respiratory tract, causing severe atypical pneumonia. Patients with MERS also have prominent gastrointestinal symptoms and often have acute kidney failure. We're still learning about this novel virus, and respiratory symptoms have ranged from mild to severe. From a review of 36 cases outside of China, the median age was 45 years old, and the range was 2 to 74 years old. 71% were male. Among 6,000 confirmed cases in China, about 21% were severe. CDC will hold a call tomorrow at 2 o'clock to discuss interim guidance for clinicians. The current clinical guidance is based on experience with SARS and MERS and will change as more information is learned. China has reported transmission before symptoms appear, which differs from SARS and MERS. CDC is gathering data on whether asymptomatic spread with the 2019 nCoV may be happening. If we look at past outbreaks in comparison, it helps us understand and put in context this new virus. The case fatality rate of 2019 nCoV has been fluctuating as new information comes to light. On January 23rd, the World Health Organization estimated it at 2 to 4%. MERS was first reported in Saudi Arabia. Since then, there have been nearly 2,500 laboratory-confirmed cases, including more than 850 deaths, roughly 35%. It has a much higher case fatality rate than has been seen thus far with this novel coronavirus. So far, all MERS cases have been linked to the Arabian Peninsula. SARS was first reported in China in 2002. It spread to more than 24 countries in North America, South America, Europe, and Asia before it was controlled. During the outbreak, about 8,000 people worldwide became sick, and the case fatality rate was about 10%. There have been no cases reported since 2004. R0 is a term that indicates how infectious or contagious a disease is. It tells you the average number of people who will catch a disease from one contagious person. The World Health Organization has estimated an infected patient with the 2019 nCoV can pass on the virus to anywhere between 1.4 to 2.5 people. Measles, in comparison, is much more contagious, with one person spreading that disease to up to 18 other people. However, the complete clinical picture with regard to 2019 nCoV is still not fully clear. There are ongoing investigations to learn more. The World Health Organization's strategic objectives are to identify, isolate, and care for patients with this novel coronavirus early, including providing optimized care for infected patients. They aim to identify and reduce transmission from the animal source and to address crucial unknowns regarding clinical severity, the extent of transmission and infection, the treatment options, and to accelerate the development of diagnostics, therapeutics, and vaccines. They aim to communicate critical risk and event information to all communities and to counter misinformation, and importantly, to minimize social and economic impact through multi-sectoral partnerships. Federal agencies here in the United States are taking many steps in response to this outbreak. Their goal is to contain this outbreak and prevent sustained spread of 2019 nCoV in the United States. Public health entry screening was quickly implemented at 5 U.S. airports for travelers from Wuhan. It is now being expanded to 20 airports, including Dulles. CDC has issued a Level 3 travel advisory recommending that Americans avoid all non-essential travel to China. CDC will share its new diagnostic tests with domestic and international partners in the upcoming weeks. They have uploaded the entire genome of the virus from all 5 reported cases in the United States to GenBank. CDC also is growing the virus in cell culture, which is necessary for further studies, including for additional genetic characterization. Research on possible therapeutics is ongoing, including on the antiviral remdesivir and on monoclonal antibodies. Development of a vaccine is underway in the event that it is needed, though it will take months to develop. Phase 1 trials will begin within 3 months. They will then collect safety data for 3 months. After that, it could go on to Phase 2 trials. Information and guidance is being developed and is on the CDC website. In Virginia, we are coordinating very closely with the CDC and other states. We are providing information to healthcare providers to ensure early case detection, and we are advising about infection control. We are either providing guidance from CDC or when it's not available, we're working on interim VDH guidance. The state lab, DCLS, has also provided guidance and is pre-positioning lab kits. We are case managing patients under investigation for the novel coronavirus and conducting contact tracing and monitoring. We are also proactively preparing for the potential of further spread in the U.S. should that occur. We're developing information for the public and targeted groups. We have created a web page, and we're providing updates through the media. We're also providing targeted message to specific groups, for example, clinicians, and then colleges and universities, the Department of Education, and local emergency managers. Criteria for patients under investigation for this novel coronavirus are intended to serve as guidance for evaluation. Clinicians should contact their local health department to discuss cases that meet this definition. While it's likely to change, the current case definition is fever and symptoms of lower respiratory illness and either history of travel from Wuhan, China, or close contact with a person who's under investigation for 2019 nCoV while that person was ill. And that would be in the last 14 days before the person's symptom onset. Or fever or symptoms of lower respiratory illness and close contact with an ill laboratory confirmed case in the last 14 days before symptom onset. 4 PUIs have been identified in Virginia, 2 in the central region and 2 in the northern region. These individuals met both clinical and epidemiological criteria for testing for the novel coronavirus. 2 have tested negative and are not cases. Tests are pending on the other 2. As of today, there are no confirmed cases in Virginia. CDC has issued infection prevention and control recommendations for healthcare settings. These include preparing for potential cases by training and educating healthcare personnel, implementing engineering controls, for example, physical barriers or partitions to guide patients through triage areas, curtains between patients in shared areas, closed suctioning systems for airway suctioning for intubated patients, and as well as appropriate air handling systems. They also recommend implementing environmental infection control and establishing reporting within healthcare facilities and to public health authorities. A 2019 novel coronavirus hospital preparedness checklist is available on the CDC website. Recommendations include standard contact and airborne precautions, including the use of eye protection, managing visitor access and movement within the facility, and monitoring exposed healthcare personnel. PUI should be asked to wear a mask a face mask as soon as they are identified. They should be evaluated in a private room with the door closed, ideally an airborne infection isolation room. Healthcare personnel entering the room should use standard precautions, contact precautions, airborne precautions, and use eye protection. Currently, testing for the novel coronavirus must take place at the CDC, but in the near future, CDC will share these tests with DCLS. DCLS has issued guidance on specimen collection for PUIs. It is posted on the DCLS and VDH websites. Testing for PUIs will be coordinated by DCLS. They provided all Virginia Sentinel laboratories with one 2019 nCoV specimen collection and shipping kit. 2019 nCoV specimens can be shipped as Category B. For patients under investigation, DCLS will also conduct testing for influenza, RSV A and B, parainfluenza 1, 2, and 3, adenovirus B, E, and adenovirus C, human metapneumovirus, and human rhinovirus. Please immediately notify your healthcare facility's infection control and your local health department if you suspect a patient under investigation. We have developed interim guidance for monitoring healthcare contacts while we await more information from the CDC. For healthcare or laboratory personnel exposed to a PUI, self-monitoring is recommended until lab results are received. For healthcare or laboratory personnel exposed to a confirmed case, if appropriate infection control precautions were not used, active monitoring will be needed for 14 days after the last exposure, and we will evaluate on a case-by-case basis the need for restricting activity. If appropriate infection control precautions were used, self-monitoring will be needed for 14 days after the last exposure. We recommend that you prepare now for your occupational health program to conduct monitoring in coordination with the local health department and to review policies for sick leave. We have also developed interim recommendations for EMS providers. These include obtaining a travel history from patients with fever and acute respiratory illness. For patients under investigation, place a mask on the patient as soon as possible. Utilize standard precautions, contact precautions, and airborne precautions. Use eye protection when treating and transporting. PUI should be transported to the closest appropriate facility. PUI should be placed in an appropriate isolation room, and we recommend using any EPA-registered hospital disinfectant on work surfaces and equipment. So take-home messages. As noted in the webinar today, this remains a rapidly evolving situation. Guidance will change. We've learned a lot, and we're proactively planning for transmission in the United States should that occur. We are applying lessons learned from past outbreaks and Ebola and influenza pandemic planning. There's a lot we don't know, though, and we're working closely with CDC to learn about this virus and how it's affecting people. Case counts continue to grow, and as I said, interim guidance will change. Vigilance and frequent communication with coordination between healthcare settings, clinicians, and public health is crucial to protecting our patients, healthcare workers, and ourselves and families. We also can't forget that it's flu season, and it's important to promote the steps to prevent flu and other respiratory illness. Please visit our website for updates. We have links there to the CDC guidance. You can also visit directly the CDC website and the World Health Organization website. Thank you. We received a question about how are we defining fever. The CDC has not established a specific measured temperature, so feverish or an elevated temperature could be used. We received a question about the process at the airport for returning travelers. So travelers from Wuhan, China are being funneled into one of 5 U.S. airports. That's been in place since January 17th. The numbers are very low given the travel restrictions in China. In addition, enhanced screening is being implemented for travelers arriving from China at airports with quarantine stations. This includes Dulles. This screening consists of 1, a traveler completing a short questionnaire about their travel symptoms and contact information, a temperature check, and observation for cough or difficulty breathing. And if sick travelers are identified, CDC evaluates them further. If they have no symptoms, CDC will provide an information card that contains symptoms to look for and what to do if they develop symptoms. So incoming travelers from China are self-monitoring for symptoms. If they develop fever, cough, or difficulty breathing, they are recommended to seek medical care, but to call ahead before going to the doctor. We had a question, which we did answer, address it again, of whether data suggests that people are infectious prior to the onset of symptoms. Chinese officials have reported that they have had, that this could be the case, but at this point, CDC does not have information and is doing studies to evaluate this. We had a question about, given the spread to multiple countries, do we recommend that healthcare facilities screen for any international travel history or focus on China? So we always recommend that ill patients are asked about their travel history. We, of course, are particularly concerned about patients who have traveled to China and who could possibly be a patient under investigation. This could change if person-to-person spread is happening in areas outside China. So we had a question about, is quarantine and monitoring of returning travelers, how is that being handled? At this time, CDC has not recommended monitoring of returning travelers unless symptoms develop. We had a question about expanding the case definition to the PUI to include all of China. So at this point, CDC has not updated that, but we are expecting the case definition to be updated. As soon as that information is shared, we will update our website to include that new definition. So again, we recommend that you continue to check our website for the latest clinical guidance. We had a question about how quickly lab testing for a PUI would be returned from the CDC. CDC has said initially 24 to 48 hours, but it is taking longer now. The volume has increased, and so it could take longer. We don't have an exact number of days.
We've had a question about waste management and management of laundry, food service utensils, and medical waste should also be performed in accordance with routine procedures. We've had a question about monitoring returning active duty military professionals, and we are not sure at this moment, so we will obtain some guidance and send it out with the recorded webinar as well as with the rest of the questions.
Thank you for taking time out today to receive this update. We appreciate your coordination, your collaboration. Please make sure that you have close coordination and communication with your local health department. If you have questions, you can also email respiratory@vdh.virginia.gov. So that's respiratory@vdh.virginia.gov. Thank you again.